Hello everyone. This is Sadhana Alangar, HL7's Director of Education, welcoming you to the CMS's new interoperability rule and its impact on payers webinar. Our presenters today are Swanand Prabhu Tendolkar and Guninder Bhatia. Both are joining from CTS Tech. Swanand is the Senior Vice President of data management at CTS Tech. He has over 20 plus years of experience across healthcare regulatory reporting, standards, and frameworks, including HL7. He has also served as the senior architect for development of CTS Tech's BI clinical products. Prior to that, he was with Epic System, where he worked on development of the Epicare product. He holds a master's degree in information technology from IIT Mumbai. Guninder has over 10 years of experience in the healthcare IT industry across both payer and provider organizations. She has extensive knowledge of healthcare workflows and technology. She's a certified Scrum product owner with a focus on developing innovative solutions for payer organizations. She has worked across business analysis, solution design, and IT consulting. She holds a master's degree in computer applications. At this time, I would like to hand over the program to Swanand. Hi, Swanand.
Thanks, Sadhana, and let's begin with this. Okay. So, hello everybody, and thanks for joining the webinar today. We'll be going through the new interoperability rule proposed by CMS sometime in February this year. And as part of webinar, we'll be focusing mainly on the impact on payers. Nevertheless, we'll be touching upon the use cases for providers as well. As part of this webinar, you can see this is what we are going to talk about. The first is demystifying the CMS interoperability rule, getting an overview of it, the emerging industry trends as well, and what goes in the value-based business model, the need to have new data-driven models and stuff like that. And then we'll be summarizing the interoperability rule. And the next thing that we'll be talking about is understanding the impact of the rule on payers. By addressing the data challenges that they probably would be facing, because CMS has brought in new ways to exchange data. What you need to do in terms of leveraging technologies, how do you overcome interfacing challenges, the data format variability, data quality, or maybe aggregation of data, patient longitudinal records, and all those good stuff. We will also briefly touch upon what payer needs to do due to this rule that has come in picture. Before we begin with this, these are some of the frequently asked questions. These are the questions that we received during our previous webinars, and also these are the questions that we keep hearing from our customers who are our existing payer customers. So first is, what is the anticipated time frame for the CMS rule to come into effect? What are the set of data elements do payer need to share to improve the care coordination between themselves? What members, what can the members use for FHR access to their EHI? So nowadays members are going to get access to their health data, and how they can use it is basically the question. What are the added benefits for payers to comply with the rule? If I comply, what's in it for me? And what are the minimum requirements for payer to, from payer perspective, to comply with the rule? We hope to answer these questions as we go about the webinar. And let's go to the next slide. Here is the formal agenda. The interoperability rule and CMS proposed rule. We are going to talk about that first. The next, we'll look at the payer current ecosystem and the future state of payer ecosystem, how it's going to look like. The key use cases and their impact. And the last we'll take a dig at what's next for payers. So what is it that they probably need to do in terms of their IT infrastructure, changing their word of handling data and stuff like that. We'll take a dig at it from our perspective, what we look at it. The next is a polling question. It's a pop quiz for everybody. And Gunita, can you launch the poll, please?
Sure.
So this is about what is the biggest barrier that you face in your interoperability journey. Is it unstructured data? Is it a lack of HHS or CMS support? Is it that integrating with new solutions with the legacy system? So we'll just wait for maybe like 10 seconds or so out here for people to answer. And once Guninder closes, we'll move forward. Okay. Maybe just 2 more seconds and we'll stop and we'll go ahead with it. Yeah, Guninder, you can stop. Yeah, just stop this poll. And what we see is it is clearly divided in unstructured data and integrating new solutions. These are the two biggest barriers that we see that the people are talking about currently. And probably we are also thinking the same, and we'll see how to go about it in our journey. Okay. Let's look at the interoperability journey over the past 10 to 15 years, what has happened before we get into the actual rules. So from the time frame of 2004 to 2009, we saw the rise of High-Tech Act that got passed. We also saw the rise of Nationwide Healthcare Information Network, the good old NN as we used to call it. Office of National Coordinator was created for Health IT during this time, and Health IT was started becoming a lot more formal from federal perspective. We saw around 16 to 20% basic EMR use during this time. The next phase was from 2010 to 2012, and during this time, what we saw was meaningful use came in. That's exactly what popularly called as Obamacare, and they brought in the meaningful use. The stage one began at that time. CCDA was launched during this time as one of the improved formats for clinical data exchange. It was more of a XML structure rather than the previous HL7, which was pipe and tilde and comma delimited. Blue Button initiative was also launched during this time frame. At that time, Blue Button initiative was more for HL7, that is the previous version of HL7. It was being used as a data exchange format. The next time frame is 2013 to 2017. And this is the time when we saw Commonwealth, that is an industry-led network system that was launched. Argonaut project was also launched using FHIR, and meaningful use stage 2 was also started during this time. And this was also a time when we saw a drastic increase in EHR adoptions. Around 80% was adopted. And this is where interoperability started getting into thick of the things and started becoming a big deal. Last year, we saw few things. The Blue Button, they launched once again. They brought in the version 2 of Blue Button. And this time, Blue Button said, okay, we want to use FHIR as a data exchange format. The Da Vinci project was also launched. That was to bridge the gap between payers and providers. And many payers are currently part of Da Vinci project, and they have been working on it. My Healthy Data was another initiative. This was launched last year. Again, this was to give patients more control of their health data, who accesses their data, who should not access, all of those things. They're trying to give it to the members, and just to give them more control of their data and give them more comfort that yes, their data is not getting misused. With all this history, for whatever we have seen over the last few years, this year, CMS proposed a new rule, that is the interoperability and patient access rule. IPAP is the way I like to term it, interoperability patient access proposed rule. This is what CMS brought in the month of February. And with all this history, I would like to hand it over to Guninder. She would lead us through what the rule is all about and its impacts on payers. So it's going to be bulk of this talking done by Guninder from here on. So Guninder, over to you.
Thanks, Anand. Hello, everyone, and I really appreciate everybody's time today to join us on this webinar. Well, as of now, I think everyone is well aligned with the fact that interoperability is turning as a big buzzword in healthcare industry. And as we have seen in the earlier slide shared by Swanand, that many initiatives have been taken towards towards it. But still, I feel the pace is not as required. It's still slow. So to continue the push towards interoperability, CMS has again come up with a proposed rule for interoperability and along with the patient access, which not only aim to strive for the greater interoperability, but also truly empowers patients or the members to obtain and share their health data easily and securely. So today in my following slides, I'll be taking you through to this initiative and try to make it as informational as possible for me. So let's go into the rule. Well, anyone under public or state plan that's been funded by the government. So you have, the Medicare Advantage, Medicaid Managed Care Plan. So you have the qualified health plans. Those are the QHPs. And then you have the CHIP agencies or the state agencies. So if you are one of those, then this rule is going to impact you. Well, the broader commercial market, the employer-sponsored health plans, and the standalone dental health plans are currently exempted from this rule. So the rule basically spins around 8 key aspects. The majorly the 5 in the blue are for the payer side and the remaining 3 are for the provider side. I'll be talking about both during my discussion on these slides, but would be focusing more on the payer impact while going through the following slides. So let's see what these all about. The first one says the patient health data exchange, that is to provide meaningful and insightful information to members and thus making it better for their member engagement and strengthening their relationship with their health plans. Next is to improve care coordination between payer to payer by just sharing the member historical claim data information. Going next in line is API-based provider directory information that not only helps to give a complete picture for the provider information, but also helps to remove the inconvenience caused by inaccurate information published on the portals. Next is if you haven't already connected to the trusted exchange, so better get on. Build out your connections or get certified to be the part of these trusted exchanges. Last, on the payer side is improving the experience for dual eligible individuals. So let's quickly move to the provider side, which says the first one is on the patient ADD event notifications, I think, which is one of the series of interoperability related changes to its condition of participation. The next one in line is the prevention of information blocking. And the last one is the provider's digital contact information. So this is just a brief, let's take a deep dive into each requirement of the rule for payers. Let's go one by one. So what's there in the patient APIs? The rule asks for members or the patient information to be available via APIs. Now, what's these APIs are? APIs are nothing but I think you all are very much familiar with it. The application programming interfaces, that is nothing but a standard to allow two applications to talk to each other. So the data that's going to be available via these APIs would be adjudicated claim data, provider remittance data, encounter data from the capitated providers, and the clinical data. And if the plans or if you are storing the lab result data also, then you must be able to share that out. So how this will implicate or how this will impact the plan? Well, the one key requirement is to implement and maintain the API using FHIR. FHIR, I think it's not a big name nowadays. Everybody is quite familiar with FHIR. So FHIR is Fast Healthcare Interoperability Resources, which is a standard given by HL7. And it is quite becoming a staple protocol for joining disparate systems together and thereby, unlocking silos of member and patient information. So it is like if you haven't already made any support for FHIR, you need to get equipped really quick, either partnering with some vendors to get help on your FHIR implementation. So you need to drill down what are the FHIR resources available. If you haven't already put some type of interface to the end consumer, right, you need to prepare for it. So there needs to be some kind of a data repository, or you can enable your current data repository, but it's recommended that you actually either map or put an interface to your data repository so that it can be structured and modeled under FHIR standards. So the next in rule is, what rule is saying that it's specifying the response time for sharing the information via API. So you have to make the claims available within 1 day of adjudication. And the same goes for the encounter data as well. So I feel these are another task for plans to get equipped with when they are going for the first requirement of the rule. The next in line is the historical data and the care coordination between payers. So the rule allows member to access their historical data even though they switch their plans. So it's like if asked by any beneficiary, the plan would be required to forward the beneficiary information for up to like 5 years to the new plan or any other entity identified by the beneficiary. So I'll just make it more simpler. Just cite an example here. So today, if I am enrolled with plan C, and 5 years ago I was with plan A, and 4 years ago I was with plan B. So in my current requirement, I'll just go and ask my plan C that I just want to have all the information history for my last 5 years. So my current plan C will go out to all my previous plans, pull the information together, aggregate into one location, and make it available to me via patient access APIs. So that I could access it on my smartphone. That would give patients, the kind of insight on treatment history or to the prescription drugs that I have taken along, or the providers who have billed me for the services. So all this information is aggregated at one place, and I can have a look at them even though it's my historical data. So now if I talk about the impact of this, it's like now the payers, or maybe payers, need to make sure that they should be having a set of data, a set of provisions in place to exchange this electronic information. Are you using as an API, or you are connected in an HIA? How are you using the HIA platform or the protocols? So as you know, actually exchanging the clinical data or the patient data at this point. So you need to have a repository to share member longitudinal records coming from different other payers. And also the rules specify, like the payers must be able to exchange data as outlined by US CDI format. So while going through with all this, the payers must need to answer all these kind of questions and make a provision for exchanging member historic data. So the next one in line is maintaining and publishing provider directory information. This probably been already driven through the portals, but now you have to publish this information via APIs. So it has to be updated within 30 days of changes have been done, like if the provider moves out of some different facility or changes his contact information, that update needs to be updated within 30 days. So well, here I don't think there would be much impact on the payer side, because this information is already available to them and they just have to map this data to FHIR resources and make it available on the APIs. So basically the idea is it can avoid any kind of confusion and inconvenience for members due to incorrect or inaccurate information. Going next with the fourth one, that is participation in the trusted exchange network. The CMS is looking out for participants that should be having the capability of exchanging member health information between different entities, peer-to-peer, peer-to-provider, or any other participant of the trusted exchange network. So well, if I just talk about these trusted exchanges, they are more like network of networks, which are based on certain principles and ground rules for sharing data in between HINs and other participants. So here, if I'll talk about the impact is like now we are exchanging the PHI data. So you need to be onboarded with certain kind of rules or certain type of trust to exchange the data. So you have to go through some certification process or some onboarding process to uh, get registered with this trusted exchanges. And much of these details about the onboarding and the certification is through the TEFCA framework. Well, the trusted exchanges networks are not yet fully defined and they are still evolving. And also the rule has not much specified on these details. But yeah, in our view, we will think that this will really going to allow the broader interoperability scope beyond one health system or to point connections among payers, patients, and providers. So I think the idea is to use APIs or to have a direct connect between the trusted parties to have a secure exchange of PHI information. So such networks will establish rules for the road ahead for this interoperability, and with the mature technology, they will really gain momentum with other participants like the federal agencies, the EHR vendors, or the provider associations, and even the individuals also who will be participating in this trusted exchanges. So going ahead with the last one on the payer side, that is to increase the frequency of federal and state data exchanges for dual eligible individuals, which is currently, I think, weekly or monthly, and the CMS is encouraging to make it on daily exchange basis. So what happens in the monthly exchange? It takes multiple months to correct and resubmit an improperly processed transaction, which not only adds to delay in assigning premium liability, but it also leads to larger mispayment and kind of redistribution of premiums. Thus, just to improve coordination of benefits and reduce this misallocation of funds, even when the enrollee is changing its status, so CMS is asking states to exchange this buy-in data on the daily basis. Well, this is what we have as a highlighting requirements for the payer side. Let's quickly go through what the rules call about for the Medicare participating providers. Although we'll be focusing more on the payer side, but I'm just touch basing what we really have for the providers. So the first one is on that ADT event. So what CMS is proposing is as a part of series of interoperability related changes to its condition of participation. So under the proposed rule, the Medicare participating hospitals now are required to send automated patient admission, discharge, or transfer notification as and when that event happens to the other facilities and the other providers connected to the patient. Although the CMS has limited the implication of this provision only to providers, but in our view, I think if this timely information is extended in scope and shared with the care managers, it would be a real key contributor for payers to close the care gaps and also, help them in improving the care management programs. So next in line is the prevention of information blocking, which asks for the publicly reporting of the names of providers that are involved in any such activities which could be considered as information blocking. So any practice that limits interoperability purposely or otherwise is information blocking. So like practice of restricting authorized access or exchange of information due to non-standard technology implementation or due to inability of EHRs to exchange data could be the part of information blocking. So which I feel is really a good initiative from all these regulatory bodies to disclose the bad actors who are stopping the road ahead for the interoperability. And the last one in line is the provider digital contact information. So it is like the clinicians now have to submit their digital contact information in the system called NPPES, that is the National Plan and Provider Enumeration System. and failing to do so again will ask for the public reporting for all those. Well, going next is our rule timeline. As Swanand mentioned, the rule got proposed in the recent month of Feb, and it was open for the comments till 3rd of May. But later, the comment period got extended till 3rd of June. Now here we are, and as per the rule, the Medicaid and the the implementation of the API for the Medicare payers has to be done by like January 2020, along with the registration in trusted exchanges. And lastly, for the Medicaid and the CHIP managed care plans, it is for July 2020. So they got little extension for that. But as many of the industry experts have commented, and we also hold the same opinion that the timelines are really aggressive. So if the rule gets finalized, payers really need to gear up hard to get aligned with it. So I would rather suggest that the timeline should be little relaxed so the payers can go slow, but accomplish more to get compliant. And also, we tend to think that the rule will get into effect by this quarter end. That is what we are anticipating as of now. So going next, I think going next, we have the payer ecosystem, where we will be having our point of view on what is the current state of art with payers when they are exchanging data, and what would be the envisaged futuristic simplified state using FHIR.
Yeah, so briefly touch upon the current one. I probably feel people will need.
Okay. Sure. So the current schematic shows the current state of payer ecosystem, and I'll be highlighting few key challenges here also. I think this is a kind of a generic view where all the payers can get aligned that the payer exchanges varied type of data, like financial data, clinical data, operational data, and the exchanges with the multiple external entities. All these different types of data get exchanged in multiple standards. Either it is X12, it is HL7, it is CCDA, or any other custom format like XML, CSV, and so on and so forth. So I think to ingest and process these varied data formats, payers really need to scratch their heads and put multiple parsers or other technology platforms, which not only just add on their administrative overhead, but also creates a real messy ecosystem for payers. Well, payers day in and out exchanges huge set of data, which should contribute to have a huge data repository with them. But due to this unstructured data format, they'll end up with a disparate and disconnected data systems, which not only help them to have a member transparency, but also doesn't help them to have a care coordination between them. Thus, I think the CMS rule or the CMS initiative CMS initiative that is recommending the one standard format for data exchange, that is the FHIR-based open APIs, can really help them to come out of this messy situation and build a connected and interoperable healthcare ecosystem to realize the benefits of digital health. So let's see how the futuristic simplified version of payer ecosystem looks like. So in the previous slide, we just saw that there are many spurring challenges in the payer ecosystem with respect to exchanging of data with multiple entities. Now, if we go ahead with the moving wave of interoperability and try to get aligned with the CMS rule, so what we envisage as a futuristic and a simplified state of payer ecosystem is the FHIR is going to be the catalyst for driving interoperability now. The same data set, either it is financial data, clinical data, or operational data, that has to be now exchanged, but it has to be exchanged using FHIR resources rather than any other format. So instead of using multiple parsers now or the other technology platforms, Now there will be single FHIR gateway, and this FHIR gateway for data exchange would be attributed by FHIR interface services, which not only map the data, which will help to transform and standardize the multiple data formats into one standard form if you are not equipped with FHIR data form, to set up endpoint connectors which will bundle together all the different FHIR resources depending upon the use case or the scenarios, and push it via APIs. Thus, I think in our view, FHIR enabled APIs would be the need of an hour, and they will eliminate the need of multiple parsers. So it will reduce the administrative cost, it will brace a digitally connected healthcare ecosystem, and also it will increase the involvement of patients in their own, in monitoring their own care. So this is the futuristic state using one standardized form of data exchange and help in improving care coordination. That is what we think would be after the FHIR comes into the picture. Well, going next, I think we have few set of use cases. Well, many of few use cases I think I have just shared during my previous slide, but just to present as a collated or the aggregated view of the key common use cases when we talk about the key highlights of the rule is, they are like here. So the first one is around member electronic information. So when the data is available through FHIR enabled APIs, so the members can, check out their latest claim status. On this all kind of use cases would be enabled through the third-party apps or maybe on the portals when the APIs are open and accessible to the developers and the other vendors. So they can check out their latest claim status in their real near time. They can have the clinical data with them when either they are going for some follow-ups or something. They can also have their cost distribution handy, which sometimes lead to confusion and miscalculation for them. So going next is like sharing of member historic data. As I mentioned, like now with the having a member longitudinal view, the member can see the medication history with them. They can easily do the comparative analysis of by comparing their vital signs and plan out for their own plan for treatment. And also, they can take proactive actions to monitor and control their health. Going next is on this provider directory information. Like now, just want to highlight before I'll go for the use case. It's like as per the ONC on report on health IT quick statistics, it is being come out like 42% of members uses smartphones for accessing provider directory information, and around 38% of members use smartphones for tracking their charges and costs. So I think these use cases would serve the purpose when the members can easily, have access of their own information. So for the provider directory also, when it will be available, so members can search practitioner or any provider on the basis of the demographics, on the basis of any region, or on the name or address, anything. Well, going next, I have few more use cases. Okay. So the next is when the payers are participating in the trusted exchange. So this would have a wide range of use cases, but I'm just highlighting few here. So like they would be having a point-to-point connection when they are participating in the trusted exchange network. The payers would be, it would be handy for them to determine whether the individual qualifies for a federal or a state reimbursements, or they can easily determine the responsibility for the coverage under the health plans. And, these are few other benefits when you participate in the trusted exchanges. And the last one is, sending the clinical alerts to the PCPs or the care managers. This is the one of the use case which is overlapping with the Da Vinci use cases also. As I mentioned, the rule has limited the implication of this use case. But if we expand the horizon and expand the scope for that, I think it's a clinical alert for any specific event. is sent to the care management, then they are the real contributor to build an encounter record and improve on the care coordination and management, and as well as help members in scheduling timely follow-up as needed. So I think I will just conclude here with the functional side of the rule and the demystification, and along with my point of view and our point of view on the current and the future state. So I'll just now forward it to Swanand.
Thanks, Gurinder. And well, folks, I'll take you through the remaining part of the webinar now. So first of all, Gurinder, can you do the honors of having the polling questions?
Sure.
It's more about at what stage the implementation process in your organization is currently. So the answer could be you're learning about the rule, you're researching the solutions, or you're contracting with maybe some of the implementers. And we'll just wait for 5-10 seconds and then we'll begin for the token sir. Okay. Yeah, I think we can start. We have a lot of this.
Okay.
Coming up. Yeah. Okay. So almost 60% of the people are saying that they are still learning about the rules and its implications, and that's what everybody in the world is doing currently. So that's good. Let's go ahead and what payers need to do. Gurinder talked about it, almost all of that. But this is more from IT perspective, what they have to do. So first is, of course, set up IT infrastructure for API enablement. Build upon the existing healthcare IT infrastructure that you would probably be having. We can definitely do that. And which also in some ways would mean that payers need to adapt to and probably need to optimize their IT product services, etc. Because this is going to be a change in their IT infrastructure. The second thing is enable seamless bidirectional data exchange framework. In some ways, we'll have to do it, correct? So with the new rule, payers need to enable bidirectional data exchange using FHIR APIs, as Gurinder said. And they also need to expose members' historic data. And in that case, and that actually brings us to the next thing that they need to do is to enable a technical standards and data aggregation. There are a few things which come under this one. So first and foremost is, of course, brace to receive the IDT alerts and ingest them. Also, in order to be able to expose patients' historical data, it would be advisable to have a robust data aggregation in place. Or patient longitudinal record creation would be the need of ours. That's what we believe. And we need to set up the IT infrastructure to authenticate external users as well. We are sure that all payers would be having IT infrastructure to authenticate and restrict access for internal and departmental users. But with this new rule, it needs to be broadened to external users as well, because the members themselves would be connecting to this one. And probably they would be connecting it through third-party app, which is probably a mobile app, or it could probably smart MFHR app. So that is something that they need to enable. The third one is that's what I mean. There is nothing, no points in guessing what it could be. Well, it goes without saying that we need to start small and achieve big by optimizing it later on. So go for a simple reusable solution. Probably keep on going to complex methods in future is what we will. Participate in trusted network. Gurinder again spoke about it a lot, but this would help in improving care coordination. But it would also mean how to connect. Right? So far, the trusted network, their definition and their way of communication with them is not clear as we all speak here right now. But what I would imagine, and this is whatever digging we have done and we have probably figured out, is one thing could be they could also be using FHIR gateway for data exchange, or they could still be using probably some sort of other format like HL7 or maybe some custom. So that would add a little bit of a change in the way this the go forward stuff looks like. Gurinder talked about all of FHIR, but trusted exchange network currently so far they haven't really prescribed anything on it. So we probably would be in for a little bit of a change out here. Last one is enable easy member health data access. real-time member data, no claims, encounter data lab. This needs to be made available within 1 day. Providers need to also, provider network data needs to be made available, and that needs to be refreshed every 30 days. That all needs to happen, and that all needs to be made available. And this needs to be made available to members with an easy data access. So probably they can think of some sort of a member portal, or maybe some sort of a mobile app that can be residing on members' handheld, and they can access it. This is all coming to us, and we have been thinking more about it. And this probably may not be the everything that payers need to do, but at a high level, we thought that these are the 6 things that payers will have to do in order to go ahead with this. If this rules comes into effect as per a timeline sometime in January or early part of next year or so. This is where what the experts have been saying. He says the timelines should be no sooner than 2022. Yes, almost everybody is saying that the timelines are really too stringent. AMI, they have been saying that yes, this looks good, but they say that a phased approach would be really good. And they're saying that the specific data should be made available through open APIs and not everything. AMGA, again, they have been saying something similar. They have been saying, yes, they're saying that the rules is good, the significant changes have been happening, and what we need to do is, again, address the operation and technology challenges for the rule. Currently, those are not really prescribed from CMS perspective. They have been saying that this needs to be done or that needs to be done. The next slide talks about what payers are saying, and we looked at some of the payers and their viewpoint on it. Humana guys are saying that yes, we like that 2020 January, but they are still saying go for iterative approach. Blue Cross Blue Shield Association, they are saying that 2-year implementation time frame is something that is required. WellCare, they have been saying that this is also good, but they are saying that adjust the effective date. And again, if I have to read between the lines, they are also saying the same thing, that the timelines are a little too stringent and we need to do something about it. United Health Group, they are also saying pretty much similar thing. They are saying that allow sufficient time to develop appropriate standards and safe data exchange. Again, everybody is probably in unison when it is saying that yes, the timelines are a little bit, not little bit, but they are stringent. And yes, this is what we thought that we will tell you, that what we have seen that the experts in the industries are saying, and what the other payers are saying. Going to the last slide, the last portion of it, and this is where we are talking about what next, and this is our dig at it. The last polling question for you, just 10 more seconds, bear with me, and then we go ahead. What do you see as the biggest challenge going forward? Is it limited funding? Is it lack of clarity on the requirements, shorter timelines? And I kind of know the answers, but we just thought that we'll pop this question up here, and just wanted to ensure that whatever we have been saying, correct? Whatever we have been saying that the experts are saying, is this group that we are talking to today is also in agreement with the same? Let's give them 3-4 more seconds, Guninda.
Sure.
Okay, let's stop it. Okay. There seems to be a agreement. It is 1/3 for B, C, and D. Lack of clarity, shorter timelines, and lack of in-house technology experts. These are the 3 things seems to be coming out as the ones. The next one is how do you drive your interop strategy? This is our take on it. There are going to be certain short-term goals, and there are going to be certain long-term focus. The way we see it and the way we believe it should be done is, our short-term achievement should be seeding our long-term goals. To comply with our interop requirements in fully, it would be good to have patient longitudinal record in place, good practice of data aggregation in place. If FHIR standard is to be complied with, then internal data structure should also be well aligned with FHIR resources. And this is something which is more of a long-term. Yeah?
I think the slides are not visible.
Slide is visible, I believe.
No, it is not. The slide is not.
It is not?
Yeah, no.
I am sharing it actually. I don't know what I need to do more.
I think the sharing got stopped. Maybe some network or something.
Oh boy. Are you able to see now?
Yeah.
Yes.
Sorry for that. I had a network glitch here for a while, so that's why. My bad. Okay. So this is what we're driving the intra strategy, and there are short-term goals and long-term focus, as I was saying. There are many things that we can do as a long-term strategy, but as an example, what we can do is to begin with, one might create a shell of FHIR APIs for bidirectional communication without touching internal processing. And if we do not have patient longitudinal records, then what will happen is FHIR APIs would have to do extra work initially. Patient longitudinal record can get implemented in the backend later on, and it would mean the change of queries for FHIR APIs, but it wouldn't have impact on the consumers because my APIs are still the same. Similarly, if there is an internal process that takes, say, HL7 record as an input for processing, and initially as a quick phase, one might translate FHIR data coming into HL7 without touching the existing routine for the processing. But later on, as a long-term goal, the routine will be rewritten to do the same processing using FHIR data itself, and so on and so forth. The list might go on. And what we really feel is that one might drive the changes in intra-processing strategy in a fashion that achieve your short-term goals without losing the track of the long-term focus that you have. That kind of brings us to the last slide of the webinar. These are the key takeaways. We thought that whatever we spoke so far, we'll put it on one single slide: the technology, the business process, and people governance. The technology management and aggregation, the data member constant record views, what all things we need to do from technology perspective. So simplified API layer needs to be created, member matching, if you already don't have, you need to have it. Access control, OAuth2 and Smart are the ones that they are looking to go forward. There are certain changes would be required in business process. Gunit has talked about all of them, and I really wouldn't want to harp on it once again. But this is probably the last slide that we have here. And the last one is the people governance, training and upskilling of the team in the SHR. I saw the last 4 answers. 33% of you said that lack of in-house technology experts. Yes, training and upskilling would be required. Identification, verification, authentication of participants. And the last one is build strong buy-in from various IT enterprise internally and functional teams to manage allocations and it. At this time, I would like to stop the webinar from the perspective of the slideshow, and we would like to take up some of the questions. So we have seen a lot of questions coming in, and we have probably 8 more minutes to go. And what I would do is I would go probably serially. So the first one is, how often does the provider directory data needs to be updated? Did we say 30 days? Yes, it is 30 days. That's what we said. The next one is, can you define providers? Are ADT files required from hospital systems with an ER, any hospital or primary care? I mean, from our perspective, primary care can be left aside, but everything else, hospital, the patient gets admitted, ADT, so would be sent across to the patient. The next one is, when referring to trusted networks, are we talking about the direct secure messaging, air quality, Commonwealth, HIs, or others? So in fact, HIs have been in place, Commonwealth has been in place, and air quality and HINS, they all have been in place. CMS has talked about trusted networks. They will be formed, and I mean, this is our take, that the Futuristic's take on it is that they are going to be pretty much similar to HIs, but they will be a different entities than HIs.
Yeah, so just to add further to it, that they would be similar to HIs, but it would be the bigger scope for them.
Yeah.
And these Commonwealth and care quality would definitely be a kind of the vendor for them to provide and let the participants register to these trusted exchanges. So I would say these would be the gatekeepers for the trusted exchange network.
Yeah. The next one is, do we expect the Jan 2020 date to be pushed back as the requirements haven't been fully published? If you honestly ask, I mean, my honest answer to do it is yes, it should be pushed back. That's what I believe. But currently, they haven't said anything.
They haven't mentioned anything. But yeah, we also anticipate that it should be pushed off a little bit.
The next one is trusted exchange.
David has
Yes.
a question. What's the penalty for not being ready by 2020 for MA plans?
So as for now, the rule has not specified much on this, but definitely when the rule will get evolved, they will come up with the penalties also.
But currently it is proposed, so they haven't really talked about it. So far, right now we are good. But yes, we will have to comply, because I believe, again, this is what CMS believes, once when they bring the rule into effect, they'll probably comment on that as well. The next question is, yes, we kind of talked about it. The trusted exchange specific is still a draft. Yes, it is still a draft, and that's the reason why we believe that the Jan 2020 deadline could probably be uncertain and needs to be pushed ahead a bit. All of us are saying that. Everybody in the industry is saying. The next question is, what are the numbers we are referring to on slide 13? Claims attrition, for example. So that's basically those are the EDI Excel message numbers. Those are the message specification numbers which are used for sending data between providers and the payers. So one next question is, provider will still send attrition claims to health plans, and the payers will send attrifies back to the provider. Is that correct? So if you ask me, yes, currently that's the way it will be. In future, at some point in time, Fire will probably replace it fully, but right now it won't be full replacement in the beginning. But yes, if you ask me, Fire has resources for pre-auth and even authorization. But if you go ahead and look at maybe any of the Fire sandboxes that have been given by big EMR companies like Epic or Cerner, they currently have support for Fire resources for clinical only as we speak. They don't really have support for pre-auth or maybe even auth kind of maybe like 837 or 835 equivalent. They currently don't have on their sandboxes. But we expect that in future they would be coming up with that.
So adding to that, he is asking another one, like the API requirements using Fire are to patients or to providers. So I just want to answer that the API requirement is like on the open APIs. So if anybody who has access to those APIs, they can utilize those information. Either it is patient or a provider, and the patient is through the third-party apps, the mobile apps that the patients are using.
The next one is, what was the difference between future and current state again? So if you ask me, from the data perspective, the actual data perspective, they are not going to change much, but the format is going to change. So if you see the current state and the future state, the claims are still the claims, the responses are still the responses, but instead of X37, they're looking at Fire resources going for back and forward. That is one. In terms of the format it is coming in. The second one is the way we are exchanging data. That needs to be done using an API layer rather than sending batch files using maybe ad hoc mechanism like sending it through SFTP and stuff like that. So these are the two big changes. And the third one is the API gateway that a payer would create for external parties. That will be accessed not only by providers but also by the payers, by the members and the patients as well. The next one is Fire will work well for clinical data, but it will be difficult to replace external transactions. Yes, we kind of feel the same thing, and I think we touched upon this point a minute ago that most of the big EMR vendors, they still don't have Fire resources being exposed in their sandbox for pre-auth and auth kind of a data, and all of them are currently exploring only clinical data exchange through Fire. But this thing is going to make it more mandatory. The next one is the use cases on slide 16, 17. Are those defined by HL7 or those are defined by CMS? So the use cases, the inner bullets that are there, that is which is CMS has derived that we perceive this is how it's going to be. These are the details of it. The business process that was written on those slides 16 and 17 is something which is straight away taken from what the rules is. So probably in our language, but that's what the rules is in our language. And the bullets are our understanding and our interpretation how the world is going to look like.
In terms of time, I think we should just wrap up and take all these questions offline.
Probably. So I'm just going for the next one more thing. Let me see. Okay, these are some of the questions I think Sadhana answered. So thank you very much, Sadhana, for that. Peer-to-peer data exchange wouldn't have HL7 to be used for claims remittance data? Yes. I think we briefly touched upon the same thing. That will probably be going into FHIR resources for the same. I think that's the last question we'll take. We are right at the fag end of the webinar. From Futuristic team, I would like to thank each and everyone who has joined this. Believe me, these questions are at my disposal. I was not able to take all the questions, but we'll respond to you with all the questions. When Sadhana shows, gives the URL for this slide deck, we'll also append those with the answers to the questions so that you will have answers to, you'll have access to all the questions and the relevant answers as well. Okay, Sadhana, over to you for the last concluding remarks.
Thank you so much, Swanand and Guninder. Lots of information, excellent presentation. As Swanand said, I know there are so many other questions which have not been answered. What we will do is we'll put all the questions and answers as part of the presentation. Yes, we will be uploading the presentation as well as the recording to the same course, and you will get a link. Hopefully by the end of today or definitely by tomorrow, you will get a link to the recording as well as the slide deck. Thank you all for joining. Thank you so much. Thanks once again, Swanand and Guninder. Thank you all so much for joining us today. And please, our next working group meeting from HL7 is going to be in Atlanta, Georgia. Our online courses are next week on CCDA and CCDA on FHIR. Look up those information and I hope to see you soon in one of our events. Till we meet again, bye everyone. Bye Swanand, bye Guninder.
Bye,
Bye everybody and have a nice day ahead.